Neonatal cholestasis. The definition: neonatal cholestasis is defined as conjugated hyperbilirubinemia occurring in the newborn as a consequence of diminished bile flow. Conjugated hyperbilirubinemia in a neonate is defined as serum direct or conjugated bilirubin concentration more than 1 milligram per deciliter if the total serum bilirubin is less than 5, or greater than 20% of the total serum bilirubin if the total serum bilirubin is more than 5 milligram per deciliter. Epidemiology: incidence is 1 in every 2500 infants in the West. In India, 19% to 33% of the all chronic liver disease in the children reporting in the tertiary center. Hepatocellular cause is 45 to 69%. Obstructive cause is 19 to 55%. Most common cause in the first month is biliary atresia, followed by neonatal hepatitis. In the Indian scenario, biliary atresia is the most common obstructive cause, and idiopathic is the most common hepatocellular cause. Etiology: there are two types: intrahepatic cause and the extrahepatic cause. In the intrahepatic causes, idiopathic neonatal hepatitis, toxin-induced, total parental nutrition-induced, drug-induced, chromosomal anomalies like trisomy 21 and 18, sepsis like bacterial infection, E. coli, Listeria, Staph aureus, Torches infection, hepatitis B and C, ecovirus. In the endocrinal, hypothyroidism and idiopathic hypopituitarism. Metabolic intrahepatic causes: disorders of the carbohydrate metabolism like galactosemia, hereditary fructose intolerance, glycogen storage disease type 4, disorders of amino acid metabolism like tyrosinemia, disorders of lipid metabolism like Niemann-Pick disease, paroxysmal disorder like Zellweger syndrome, which is also known as cerebrohepatorenal syndrome. Other intrahepatic causes: alpha-1 antitrypsin deficiency, cystic fibrosis, neonatal iron storage disease, Alagille syndrome, also known as arteriohepatic dysplasia, and progressive familial intrahepatic cholestasis. This is the proposed subtype of the intrahepatic cholestasis. The headings: disorders of the membrane transport and excretion, disorders of the bile acid synthesis and conjugation, and disorders of the embryogenesis, and unclassified. Extrahepatic causes: extrahepatic biliary atresia, choledochal cyst, bile duct stenosis, choledocholithiasis, inspissated bile plug, spontaneous perforation of the bile duct, and extrinsic compression of bile duct. Now the clinical presentation: jaundice, hepatomegaly, colic stools, dark urine. Other signs and symptoms depend upon the specific disease process. Investigations: in the urgent investigation, CBC with the peripheral smear, CRP, liver function test like total and direct bilirubin, which is done by the Dijkhoff-Vanderberg method, alanine transaminase, aspartate transaminase, it is sensitive but lack specificity and prognostic value. Alkaline phosphatase, it has low specificity. Gamma glutamyl transferase is paradoxically low or normal in the progressive familial intrahepatic cholestasis or bile duct synthesis. PT, APTT, INR, serum albumin, it indicates the severity of the hepatic dysfunctions. Electrolyte, blood culture, urinary routine examination, microscopic examinations, culture and sensitivity, random blood sugar, pre-feed, and chest X-ray PA. Other investigations like ophthalmological examinations, blood group, direct sputum test, torch screening. Cytomegalovirus is the most common cause. Serum IgM, which is not reliable. 65 antigen assay and the CMV PCR is more reliable and specific. VDRL, hepatitis B and C, HIV, HSV, urine and serum bile acid assay, which confirm the cholestasis, might indicate inborn error of bile acid biosynthesis. TSS and thyroxine level indicates the hypothyroidism, serum cortisol level, hypopituitarism, sweat chloride test and mutation analysis for the cystic fibrosis, alpha-1 antitrypsins is an assay of the levels of often wrong before 3 months. Phenotyping of the PI is important. After 3 months, pass positivity in the liver biopsy sample. Urinary reducing substance and GALT assay for the galactosemia. Urinary succinyl acetone and succinyl acetate assay for the femoral acetate hydrolase gene for tyrosinemia, markedly raised serum ferritin, uncorrected coagulopathy, for hemochromatosis, which is finally confirmed by the buccal mucosal biopsy. Aldolase B assay in the biopsy sample for hereditary fructose intolerance, metabolic screening to be done, even can be repeated and reviewed if done elsewhere and clinical suspicion persists. Abdominal ultrasonography is advised to perform after 4 hours of fasting, give suggestive finding about the surgical causes like choledochal cyst, inspissated bile plug syndrome, choledocholithiasis. In biliary atresia, USG sensitivity is low as 73%, so cannot exclude. Triangular cord sign, which is highly sensitive and specificity, but rarely seen. Non-visualization of the gallbladder or common bile duct. GB length, gallbladder length less than 1.9 centimeter, lack of a smooth or complete echogenic mucosal lining with an indistinct wall, irregular lobular contour, no contraction of the gallbladder after oral feeding. This is the USG picture depicting the triangular cord sign, where we see fibrotic cylindrical segment cranial to bifurcation of portal vein. Now the scintigraphy or HIDA scan. Non-visualization of the radioactive dye within intestine even after 24 hours, misses incomplete obstruction in early biliary atresia. It is time consuming, expensive, significant false positive and false negative results occur. High sensitivity but low specificity. Generally adds lead to the routine evaluation of cholestatic infant, but may be of value if other means of excluding biliary obstructions are not available. Priming losses valuable time, hence diagnosis is delayed. Performing a HIDA scan is optional and one may go for a liver biopsy straightway. Useful in diagnosis of unusual causes like a spontaneous perforation of the bile duct. Liver biopsy. It is most important investigation in differentiating neonatal hepatitis and biliary atresia. Accuracy is 60% to 95%. The prerequisite is normal prothrombin time and platelet count. And the complications are bleeding, pneumothorax, and bile peritonitis. Neonatal hepatitis. This is the histopathology slide of the neonatal hepatitis, which shows markedly irregular size of hepatocyte, bile canalically reduced, Kupffer cells swollen, remarkable giant cell formations, and relative absence of bile duct proliferation. These are the hepatocytes. Multiple hepatocytes The large swollen cells.
Actually, firstly, it is like kind of say structure. Loss of globular architecture, that is the most important. That differentiates hepatitis from others. Whether you have hepatitis, first thing, and you can see the mark inflammatory cells, all cells are all inflammatory. By penetrating giant cell, whether it stays, it does not stay, does not matter. Not that you have to have a giant cell. Not here, but first of all, it does get in the absence of bilateral proliferation. And you can't see that, you can't see through the crack from here. You have a magnified view. Fibrosis or inflammatory cell infection. আমি কিছু বুঝতে পারছি না কারণ এটা যদি একটা ম্যাগনিফাইড ভিউ দেখাচ্ছে তাহলে খুব ভালো হবে।
Now the biliary atresia. The slide show proliferations of the proximal ductules, bile plugs or the lacs, extensive fibrosis, secondary paucity of the portal duct, bile ducts, and intracellular canalicular cholestasis. Sensitivity is 99% and specificity is 82 to 98%. Alpha-1 antitrypsin deficiency, hepatocellular edema and giant cell transformation, necrosis, pseudoacinar rosette formations, Cas-positive diastase resistant globules in the cytoplasm of the periportal hepatocyte. Cas positivity. Other invasive aesthetics, exploratory laparotomy with intraoperative cholangiogram is the investigation of choice and remains the gold standard for diagnosis of biliary atresia. Percutaneous transhepatic cholangiography, ERCP and MRCP. IAP guidelines on approach to neonatal cholestasis. Neonatal cholestasis, if the child is sick and sepsis screen is positive, treat sepsis. Galactosemia needs to be excluded by the urine reducing sugar by Benedict test, as sepsis can be associated with galactosemia. If the sepsis screen is negative, test for cytomegalovirus, herpes simplex virus, urinary succinyl acetone, ferritin, GALT if urine reducing sugar is positive. If the child is not sick and the stool is pale, fasting USG should be done to see for the contractility post-feed. If this is normal, then liver biopsy should be done and a specific treatment should be started. If the gallbladder is small or absent, then biliary atresia can be excluded. If there is choledochal cyst, then surgery should be performed. If there is pigmented stool, GCT fasting USG. If the USG show a choledochal cyst, the child needs to be referred for surgery, metabolic test, genetic test, and liver biopsy should be performed, and a specific treatment should be started. Biliary atresia to be excluded. If the baby is not sick, pale stool, a small or absent gallbladder on the fasting ultrasound. If age is less than 6 weeks, HIDA scan after 3 days of priming. If there is excretions of HIDA and also no excretions of the HIDA, liver biopsy should be done, and a specific treatment should be started. If the biopsy is inconclusive or biliary atresia is suspected, intraoperative cholangiogram along with Kasai operation should be done. If the age is more than 6 weeks and liver biopsy is done and which is inconclusive and there is suspicion of biliary atresia, again intraoperative cholangiogram and Kasai operation should be performed. If age is more than 90 days with ascites and age is more than 120 days, refer to transplant center. Now the treatment. Nutrition. Continue the breastfeeding. Supplement medium chain triglyceride based feed. In older children, higher energy diet 200 kilocalorie per kg per day. Carbohydrate, glucose polymers, the proteins in the dose of 1 to 2 gram per kg per day from the vegetable sources. 2 to 3% calories from the essential fatty acid. Nasogastric tube feeding in anorexic babies. Vitamin supplementation should be continued till 3 months after resolution of jaundice. These are the dose of the multiple vitamins: vitamin A, D, E, K, water soluble vitamin. So the dose of the vitamin A is 5,000 to 25,000 international units per day orally. Vitamin D 400 to 1200 international units per day orally. Vitamin E 50 to 400 international units per day or 15 to 25 international units per kg per day of TPDS form if available. Vitamin K 2 roots oral and parenteral. In oral 2.5 twice per week to 5 milligram per day. In the parenteral dose 2 to 5 milligram intramuscular, subcutaneous or intravenous 4 weekly. For pruritus, ursodeoxycholic acid in the dose of 20 milligram per kg per day. Rifampicin 5 to 10 milligram per kg per day. Phenobarbital 5 to 10 milligram per kg per day. Symptom chart should be maintained and followed while adding second or third drug. Now the specific treatment. A special infant formula for galactosemia, fructosemia and tyrosonemia. Nitisinone 1 milligram per kg per day for tyrosonemia. A specific therapy for cytomegalovirus associated neurological involvement. Herpes toxoplasma related cholestasis. For peritonitis, IV cefotaxime should be given. For septicemia, cefotaxime along with amikacin and gentamicin should be given. There is no role of steroid in idiopathic neonatal hepatitis, and we should have a management of acute liver failure. Now the surgical treatment. Kasai procedure for biliary atresia, external and internal biliary diversion for progressive familial intrahepatic cholestasis without decompensated cirrhosis, choledochal cyst excision, cholecystectomy, and liver transplantation. Take home message. Promptly refer newborn with persistent jaundice more than 14 days with dark urine with or without pale stool for proper investigation and treatment. Maintain high index of suspicion. Strictly follow protocol. Seriously consider biliary atresia as diagnosis in apparently healthy baby passing pale stool. Liver biopsy in suspected cases of biliary atresia is an emergency and it should be done and reported on urgent basis. Surgery for biliary atresia and choledochal cyst should be done before 8 weeks. In all cases, provide diet rich in calorie, medium chain triglyceride, and adequate protein. Fat and water soluble vitamin supplementation is mandatory.